Welcome to this presentation of new interRAI research, published as part of the Frontiers in Psychiatry special issue on innovations in the mental health applications of interRAI assessments. My name is Keir Johnson from Doctors Manitoba, and I will be the moderator for this session. Our presentation today will focus on the research behind the paper, The interRAI Child and Youth Suite of Instruments, an Integrated Approach to Mental Health Service Delivery. We will begin with a brief presentation by Dr. Shannon Stewart, Professor and Clinical Training Director at the Faculty of Education and an Adjunct Assistant Professor within the Department of Psychiatry at Western University in London, Ontario, Canada. She's an Associate Scientist at the Children's Health Research Institute and Associate Scientist at the Lawson Health Research Institute. Dr. Stewart is an interRAI Fellow. She's the lead developer and international lead of the interRAI Child and Youth Suite of Instruments, and she's published extensively in the area of children's mental health. Later, she'll be joined by Dr. Jeff Poss. Dr. Poss received his PhD in 2006 from the University of Waterloo, where he was supervised by Dr. John Hirdes. He has an adjunct appointment in the School of Public Health Sciences at the University of Waterloo and works as a consultant in health services research from his home in Vancouver. We will provide a web link to the articles in this special issue at the end of today's webinar. But first, I'd like to turn things over to Dr. Stewart for your presentation.
Great, thank you. I appreciate that introduction. Today I'm going to be reviewing the suite of instruments for child and youth mental health through interRAI as a result of a publication recently in Frontiers in Psychiatry. And what it focuses on is the interRAI Child and Youth Suite of Instruments. And I'm going to be showing a bit about how we can demonstrate an integrated approach to mental health service delivery. So, as many of you are aware, approximately 1 in 5 children have a mental health issue significant enough to require treatment. And yet only approximately 25% of those children who need services actually receive them. Many of these children have also experienced trauma, which has a significant impact on mental health. And yet, if we look at our service system for children and youth, much of it is fragmented and it is also very poorly funded. There's a lack of communication across specific service sectors, and as a result, there's duplication of services, there's reassessments that are not required, and multiple children are sitting on several wait lists, not accessing the timely resources and services that they need. As a result, in response to this, interRAI has developed a suite of instruments for children and youth, beginning in infancy, all the way up to adolescence and transitioning into adult services. We designed and facilitated a standardized, integrated approach to mental health delivery. It includes both screening and assessment measures and includes across different age groups as well as service sectors. As can be seen on this slide, the service sectors vary from school, and that's the interRAI education, to home care, which is the home care for pediatrics, as well as community settings, youth justice settings, as well as hospitals. And as you can see, right from birth into elder care, we can provide an integrated health information system that supports high quality data decision-making to enhance outcomes for children, youth, and other vulnerable populations. Interestingly, interRAI has a variety of different applications, even though we utilize one assessment system. So first and foremost, we have screeners, and these screeners, in this particular situation, the Child and Youth Mental Health Screener provides information around allocation of triaging and prioritization, and then it feeds into a comprehensive full assessment that has a variety of different applications. And these 4 applications, including care planning, outcome measurement, quality indicators, as well as resource allocation. With respect to care planning, this provides a case-finding methodology that actually produces triggering algorithms to identify specific needs, strengths, and specific preferences for children, youth, and their families. It's evidence-based practice that can be integrated into care planning protocols. In addition to that, we have scales and algorithms that provide outcome measurements. If we have pre-post data, we're able to look at if there is change over time in terms of whether there's improvement, deterioration, or has presenting problems remained the same. This also allows us opportunities to evaluate programs. And then the quality indicators actually provide us an understanding of quality care, and it co-varies out the individual differences of specific types of difficulties so that we can compare and contrast across hospitals, organizations, and other facilities, whether it be primary care or tertiary care. And it evens the playing field so that we can better compare services and outcomes. And then there's also resource allocation, and this also follows through with case mix systems, and it identifies who is the least expensive and most expensive child, youth, or family within the context of the services that are provided. In terms of the demonstration with respect to the Frontiers paper, what we utilized was the construct of trauma to demonstrate these 4 applications across the suite of instruments. So in this slide, as you can see, there are different instruments that are being utilized. The first is the CHIME, which is the Child and Youth Mental Health Instrument for kids 4 to 18. The CHIME-DD, which is the Child and Youth Mental Health Instrument for developmental disabilities, and then the Youth Justice Custodial Facilities Instrument for kids in conflict with the law who are in custodial situations within youth justice. As you can see, if we provide an example, the Traumatic Life Events CAP, or Collaborative Action Plan, that actually is an evidence-based practice embedded within the assessment system for care planning protocols. You can see that the highest level of traumatic life events is with children in the youth justice settings, followed by the Child and Youth Mental Health Instrument, which is for children in mental health agencies, followed by the developmental disabilities or children with IQs below 75. Similarly, if we look at different scales and algorithms that actually trigger the CAPs, we can also examine the information and the data across trauma as well as instrument. And if you look at this particular slide, as you can see across all of the instruments, whether it be the screener for intake versus the Child and Youth Mental Health Instrument, the developmental disability, or those with in conflict with the law, it actually indicates that those kids who have been traumatized have significantly higher levels of triggering rates with respect to suicidality as well as purposeful self-harm. In addition to that, if we look at different scales that can be done to look at whether a child has improved in a particular area, deteriorated, or stayed the same, this example provides information on depressive severity index, and it shows that those kids who have been traumatized have significantly higher depressive symptoms in comparison to the non-traumatized referred clinical subpopulation. So this allows opportunities also to monitor outcome over time. Then if you look at the quality indicators, this provides information, a comprehensive understanding of quality of care. And as you can see, the different scales provide information on particular areas of concern or risk, whether it be anxiety or other areas such as the depression, externalizing difficulties, risk of suicide and self-harm in children, as well as the risk of injury to others. As you can see from this graph, the recovery rates are much lower for children who have been traumatized in comparison to those who have not. And these are all clinically referred children and youth. And as you can see, the rate of improvement is lower for traumatized children and youth, even though the baseline rate was actually higher to begin with. And so there should have been a greater opportunity to improve. However, there wasn't. In addition, the fourth area in terms of the applications of the interRAI instruments includes the resource allocation, and this identifies those children and youth who are the most expensive and least expensive within the service sector and require more resource intensity in their service delivery. Similar to the other slides, if you look at the child and youth mental health instrument in comparison to the developmental disability, you can see that those children with higher levels of traumatized behavior also have higher levels of resource needs. So this particular scale ranges from 0 to 6, with higher scores indicating higher levels of resources needed. And so those who are traumatized have much higher resource allocation and needs in comparison to those who have no trauma. In conclusion, what we're hoping is that an integrated suite of instruments can be utilized not only across Canada, but internationally to support health information, as well as make strong evidence-based clinical decisions for the future. This demonstrated that using trauma, you can actually examine differences in particular subpopulations with respect to prevalence, as well as the opportunity to utilize it for decision-making in terms of outcomes as well as quality care. In addition, knowledge mobilization is really important, and being able to link and share information and communicate across service sectors is so crucial when many of these, especially the complex cases that include trauma, are sitting on different wait lists. And we want to be able to utilize and communicate effectively, utilizing high quality data to make those important decisions around treatment planning, triaging, and prioritization. And this way, it can improve the health and service delivery for very vulnerable children, youth, and their families. Thank you.
Thank you, Dr. Stewart, for your presentation. That was great. The interRAI CHIME Assessment Suite, or Child and Youth Mental Health Assessment Suite, was developed in response to the need for an integrated mental health system for young persons, as you described. And what I liked was the slide where you talked about the whole continuum. You know, you've got screening and assessment instruments for a variety of settings: inpatient, community, ERs, education settings, youth justice, custodial settings. And I wonder if you could talk about why that service system integration is so important, maybe especially for children who have experienced trauma.
Great, thank you. That's a very good question. One issue when you deal with children and youth who are exhibiting a variety of different behavioral or mental health issues, over 60% are also presenting with some type of trauma on average. And so it's really important to understand the complex needs, preferences, as well as strengths of those children and youth, so that you can better care plan around their experiences and what has happened to them, without touching on trauma, comprehensively understanding what's going on within their context and within their community, within the house, as well as within the school. You can't really care plan properly. In addition to that, they often are seen at multiple service sectors, whether it be school, home, mental health agencies, the hospital. And so it's really important that those service sectors complement one another, reduce the fragmentation, and share needed information with respect to the complex needs of those particular children and youth. And that way it enhances the clinician's time with that particular child or youth. It provides high quality data to make strong decisions around what to do with that particular child, youth, or family. It also enhances outcomes because you have a better comprehensive understanding across multiple service sectors. And in turn, because the child, youth, and the family have been heard, it actually improves client satisfaction so that they aren't constantly retelling their stories over and over again at each service sector, and rather a wholesome, holistic approach to assessment is utilized. and that information can be used for multiple purposes over time.
And you talked about this later in life, but obviously a standardized assessment system like this with really high quality data and clinical guidance is important. But when you think about that lifespan, pardon me, as children become adults and adults become elderly, why is it so important to have that standardized system across that lifespan?
Sure. So we can use the data for a variety of purposes. And for example, the 4 purposes in terms of application, first and foremost, it's a needs-based assessment. So we can make some strong decisions about what's needed for their particular case so that we can enhance outcomes over time. Because we have, for example, multiple collaborative action plans, evidence-based practice can be utilized for children and youth, and information from this assessment system can be utilized for clinicians to make strong clinical decision making using evidence-based practice, data-driven decision making that complements clinical expertise. And this way, we provide services that meet the specific needs of the children and the family because we've already provided a comprehensive assessment. So it also allows opportunities to monitor change over time, and so that we can enhance the outcomes for kids. And if there is an issue where they don't seem to be responding to treatment, we can alter the trajectory so that we can find out what areas are of still concern and how we can target those specifically over time. And in that way, we're using our resources more efficiently, using check-in and monitoring, and also allowing a child's voice in the process.
Great. And obviously, this integrated suite has multiple applications. Maybe you can tell me a bit about why that's important and how that's useful.
Yes. So there's multiple applications, and the reason why it's so important is we could use one set of high quality data, but it could be used for multiple purposes and for multiple stakeholders. So this allows opportunities based on both clinical assessment in addition to evaluation of programs. It can also actually help us understand where we need to go into the future. What resources are needed? Where do we seem to be lacking in particular interventions? And how to bolster those interventions and anticipate future needs for the clientele that we serve. To understand our clients better, we are then able to provide the services and develop more appropriate services as we see needs change. And as an example, one of the top addictions now is video gaming, and 10 years ago, that wasn't the case. And so how do we develop new processes and procedures and new intervention, innovative strategies to assist new and presenting problems? And especially with the impact of social media, what are the other ways we can look at interventions, whether it be virtual, face-to-face, and evaluate those in a consistent manner with a large database. And because we have such a large database, we're able to look at subpopulations, impacts of certain variables on treatment, and we can actually find out specific subpopulation who don't respond well to certain types of treatment. And then we can allocate more appropriate resources where they respond more effectively to treatment for those particular subsets of cases. And this allows opportunities to be more efficient and effective, and allow our resources to go farther, given that we have limited resources, yet the need is great.
That's great. I'd like to maybe bring in Dr. Jeff Poss to this discussion. Of course, Dr. Poss has a lot of background in and loves, I think, looking at different resource utilization among different populations and clients. And I imagine that interest would be applicable to the population that Dr. Stewart studies, children and youth. So I wonder, I imagine there's a variety of different subgroups that can be examined in this population using the CHIME suite of interRAI instruments. And I wonder if you can tell us a little bit about that. Why is it important? Thinking about examining different research areas such as trauma and so forth.
Unlike Dr. Stewart, who has a background working on the clinical side of children's mental health services, my engagement with this is from the data side. I'm the analyst, and I enjoy the challenges that this very rich and increasingly large source of health services information provides. But as an analyst, I think I learned fairly early that the answer to most questions, that the answer is, it depends. It depends on the subgroup often, and whether you're looking at young or whether you're looking at old, whether you're looking at males versus females. So being able to subgroup the data into cases that are collectively manageable and that can help give a more important contribution to the question. So whether the question is a research question specific to understanding a subpopulation, or whether the question it can inform service planning. So where are the resources the highest? And we did develop an algorithm that's described in the paper called the RICHI, Resource Intensity for Children and Youth in Services, in Mental Health Services. And so this output that uses a variety of measurements from the assessment can help to easily identify whether, for example, your clientele that you're seeing this year are more resource intensive than those that you saw last year, or an agency A versus agency B, that kind of thing.
Thank you for that. To wrap up, maybe a question for both of you, and I'll start, pardon me, with Dr. Stewart. What do you see as maybe the next steps to be taken when it comes to assessing children and youth mental health?
Yeah, well, I'm really someone who really advocates early intervention and prevention. And so ideally, it would be nice to back it up into maternal health, where we actually identify high-risk mums who can receive the needed supports to actually circumvent problems in their children when they're born. Right now, we're lucky enough to just recently, we're about to publish the interRAI early years, which is for babies, toddlers, and preschoolers. So now interRAI has an instruments, a suite of instruments developed right from birth to elder care. But we really would like to back up things into in utero so that we can identify those high-risk babies, whether it be due to maternal issues, socioeconomic status, or other related mental health issues, so that we can luckily improve future difficulties that children may express later in life. I think also for every dollar that we spend in early intervention, it saves us $10 in deep end service, chronic services. And so it behooves us to really not only identify high-risk children as early as possible, but also it could circumvent the suffering not only from that young child as they grow up, but also the family and the community at large.
Yeah, that makes a lot of sense to me. And, Jeff, with your analyst hat on, what are your thoughts about that?
Well, it could be a one-word answer, which would be more. So more implementation, either more within, say, the province of Ontario, where it's been quite widely used, but not universally used, but also more implementation in other jurisdictions, other provinces and territories within Canada, and other jurisdictions around the world. The better research results can come when you can collectively compare and understand the diversity of both clinical cases, but also their responses in the clinical settings from jurisdiction to jurisdiction.
That's great. Thank you both, Shannon and Jeff, for your time today and for your work on this very important and interesting topic. I know I'm looking forward to future developments in this area, as I'm sure many of our viewers are. So thank you both. Also, thank you for watching this presentation on interRAI's research in mental health and addictions. If you would like more information about this or other related work, please contact us at info@interRAI.org. That's info@interRAI.org. Thank you.
To see all the articles in the special issue of Frontiers in Psychiatry, please visit the website shown here, or click on the link posted below this video. Visit the interRAI website at any time to view new presentations on this special issue as they are posted.